because these three classifications of movements are sort of controlled by a mechanism, and the mechanisms would be the putting everything together in terms of the different pathways that we've learned, putting them all together. And so the three broad class of movements are postural movements, those movements that are designed to contract the core muscles in a way to keep us stable. Ambulatory movements, these are going to be those movements that are required to move us, so whether it be walking, running, jumping, hopping, to get us from one place to another. That's going to generally use a type of pathway or mechanisms. And then the last classification of movement would be reaching and grasping. And that is what is human, innately human, is our ability for fine control. So reaching, grasping, manipulating objects, that's fine control. And that's going to use, that would be a broad class of movement. So the key point would be that all of the regions of the nervous system contribute to each type of movement, but the pathways that we're describing in the next slides would be the primary. So the primary pathways utilized for each classification of movement utilizes different primary pathways. So let's first start talking about postural movements. So postural movements would be how we activate our core in response to particular types of movements or perturbations, right? Like losing balance and stuff, how we contract our core to maintain our stability. Now this movement, in terms of a goal, is to provide orientation and balance. So this is what we define as equilibrium. So this will include orientation of the body and the head to the vertical. And then what it is, so that way we're all sort of positioned based to which way gravity is pointing. And it's also going to include movements that are going to initiate our core and posture muscle activation to anticipate or react to perturbations. Do you guys know what that word means? Like losing your balance? Our body is going to contract our core muscles in a way to make sure that we remain stable, we remain upright, or remain in whatever position we're trying to be in. And so what that is, in terms of like a neuroscience perspective, what your body is trying to do is maintain its center of mass relative to the base of support. So the base of support would be like the distance between your legs, or if you're like on all fours, the distance between what's touching the ground. As long as you keep your center of mass within that sort of box, or in that, in the base of support, you're not going to lose balance. You're not going to topple over. And so neurologically, with postural movements that are designed to maintain stability, we're trying to keep our center of mass within our base of support. And because it is a movement classification that most utilizes core and posture muscles, what would be the tracks that it's going to utilize? It's going to utilize the medial upper motor neuron tracks, obviously. So that's going to include our reticulospinal tract, our vestibulospinal tracts, medial and lateral, as well as the medial corticospinal tracts. Does that make sense, everyone? Medial corticospinal tract was for conscious activation of our core muscles. The vestibulospinal tracts, that was the medial and lateral. What was the medial one for, guys? Medial vestibulospinal tract. Yep, postural, but what specifically did it activate? So Alana, and guys, it's not that it turns its head. Remember that these tracks are for core and posture. So if I lean, okay, so let's say I'm going to look at you see a poster on the wall. So I'm going to look at the poster on the wall while I'm walking. So as I turn my head, or as my head is in a different position, my traps and the neck muscles and my back muscles are going to sort of change the way that they're contracting to hold your head in that position. Right? So depending on which way your head's turned, you need a different activation of the neck and shoulder muscles. Right? Does that make sense? Because remember, in terms of senses, humans put sight as primary. So it's very, very, very important to keep our head straight, or else if it's moving, we can't try to read while turn your head. Can't. So that's what the medial vestibulospinal tract does. The lateral one is for when we're standing, right? Like our inner ear tells us which way gravity is. So if we're standing it activates the extensor muscles. So that way there is sort of a baseline upright position. That's why people can sleep while standing. Sorry, stand while sleeping. And the reticulospinal tract is for baseline tone and activation of the core muscles. Okay, that's when the brainstem. So therefore, in terms of postural movements, we can activate our core muscles or posture muscles in a feed forward way or in a feed back way. Feed forward would be that, for example, when we decide what muscles we're going to contract from our motor planning areas, right? Our premotor cortex first looks at, okay, so this is the motion we want to do. We need to activate our core in this way, so that way we can perform that fine control. That would be feed forward. You're activating the core for an anticipated movement. Whereas, what if I'm standing with my eyes closed, right? And someone pushes me. I'm reflexively going to try and like fight back so that way I keep standing. My core and my stability is acting in response to a perturbation or a loss of balance. So your postural movements can be acting in both a feed forward or feedback mechanism, but they do utilize the same tracks. Does that make sense, everyone? Good. Awesome. Okay. So in terms of the senses that we would utilize to maintain balance or posture, and this is important clinically because a lot of people come in with like poor balance, right? We use 3 main senses to regulate the activation of those medial upper motor neuron tracts to maintain balance and stability. We utilize somatosensation, so we use our sense of touch and proprioception, and that's going to give us information on what foot is bearing weight, if the ground is unstable, the relative position of our body. We're going to use that to help maintain our balance. We're going to most utilize vision, and vision is going to tell us about where we are positioned in space and information about the environment. And then the last one in terms of senses is our vestibular system. And our vestibular sense is going to be our inner ear that's telling us which way gravity is. So utilizing all 3 systems, we activate our medial upper motor neuron tracts. We activate our core and posture muscles in a specific way to maintain balance for that real-time situation. Now, how do we know of the 3 senses which one we utilize the most? We do it utilizing a system called, this is a diagram showing how we use the 3 senses to maintain posture, but we utilize a system called posturography, and I do recommend that you look at this video right here. Now, have you guys ever been in a car and you're like just chilling at a red light, and then you look over, and then the car beside you starts moving, and then you freak out because you think that you're moving, and you're like, It's because your eyes see the car and tell you, vision is primary. And so this is why you always get optical illusions. Your vision, because it's primary, can trick the other systems. Right? So your sense of, and then you kind of figure it out and you're okay after that, right? It's because we best utilize, or we most utilize vision, and so we can use that sense in accurate ways sometimes. But posturography is sort of like a clinical sort of method. It's used in research to test people's posture and to look at the different factors that contribute to maintaining balance in the motor system. And so utilizing posturography, you have someone sort of standing in this cage where you have the ground that can move, or you have the wall that moves. So you can have vision telling you you're moving while you're not actually moving. You can have the wall moving when you're not moving. You can have the floor move when the wall's not moving, or both can move together. So utilizing those sort of ways, you can see whether or not the floor moves, but the wall doesn't, or if the wall moves and the floor doesn't, which one will trick us. And it's the wall moving that gives us the biggest error, which means we use vision more than the other 2 senses. Clinically, we use posturography to assess neurological patients and older patients' stability, and then you can use that as a method to see how well the rehab is progressing. So if you look at that video, you can see it. Sometimes you use muscle EMG in research to look at like the activation of muscles. Some studies have looked at like in regular people, in asymptomatic or in control groups, we see that in the order in which we activate our core and posture muscles and the muscles in our body, we utilize them in a proximal to distal activation. So if you're going to maintain balance, you typically activate your trunk, then you start moving distally. So ultimately, the last muscles will be. You activate them in a distal to proximal activation. So in posturography, you are tend to activating like your calf muscles. Then you start to go do your quads, then your hips, and then your back. So that's normal. And then, then this is my point, is that when we see like clinical patients, what we notice is that based on sort of the errors that they're having, and for all different types of sort of conditions, we see that the pattern changes from a proximal to distal activation. So they tend to try and balance first with their core, and then they go to their hips, and then distal. So it's the opposite. You guys okay with that? And it could be for lots of different reasons. It could, a lot of the times with diabetes and stuff, it's because like they lose sensation in their feet, so they can't utilize proprioception, right? Like remember how we were talking about interneurons and how the reflexes all sort of work together, right? Like if the muscles start moving, there is going to be some control of the feet just based on reflexes, and then it should progress up. Then your body recognizes it's moving, and it comes back down and adjusts it. So basically, when we see neurological conditions or issues with problems with the neurological system, no matter what it is, we see that the sort of wiring and the sort of control systems don't work in the same manner. And so therefore, as a rehab person, right, so for all of you, the best way to rehab is to sort of try and like mimic the way that it normally works, and hopefully you can sort of trick everything to come back together. So that's posturography. The second class of movement is ambulation. Ambulation just means moving from one place to another. So that would include walking, hopping, stepping, stairs, trying to get your body from one place, crawling from one place to another. And it's typically in a rhythmic fashion. This also utilizes those pathways that we've talked about. Now, what was the pathway that's associated with the midbrain locomotor region? The region that sort of initiates the rhythm of walking. It was the reticulospinal tract. And we saw from the basal ganglia lecture that we have the initiation of walking through that midbrain locomotor region, but it is processed in terms of sort of coordination and in terms of providing smooth movement. It is regulated through the basal ganglia and the cerebellum. And then we have conscious control. So we have fine control of our ankle movements. So think about this. When you guys are walking, and then you're trying to walk by someone that's like slow, like get on my lane. You want to like speed up your walking? Try this. I don't know if you guys are at home. I mean, probably. You tend to quickly try to step your feet faster. Like you flex your quads. You flex your gastrocs. So it tends to be that with the rhythm of walking and control of our hip movements, and then we have, so that's the rhythm, right? That's not conscious in a sense. And then we have our fine control of our distal muscles, the gastrocs, to try to change our walking rhythm. And that's also going to mean that we utilize sensory information in this sort of pathway to sort of help regulate. Like, remember, your body is going to take proprioceptive information, sensory information, and the regulatory centers, and it's all sort of working together. Are you guys okay with that? Do you guys believe me with the gastroc thing? You can't make rhythm conscious like when you're running. No, you can. Remember, our conscious control can supersede everything. But once you start running, is there any runners? Once you hit stride, your rhythm, you stop thinking about it. But then you can start focusing on different areas, right? but because I'm a runner, right? Like I run competitively. Once you get a rhythm, you're not focusing on like hips, quads, knees, ankles, core, everything at once. I tend to like focus in on, oh, my right calf is getting tight. I try to like flex my quads more. Like you pick spots, right? So with running, and for different types of locomotion, right, it's going to be dependent on the type of motion that you are. But what happens is, right, yeah, exactly. You try and think about different areas to adjust it, but your brainstem is maintaining the rhythm. Try to do the same thing. If you do like those like funny races where you try to like beanbag races or like crawling races or any type of motion, your body tends to make it a rhythm, right? It finds a rhythm and then make sure that you keep up that rhythm and then you can consciously adjust stuff. That's ambulation. It utilizes, again, the medial upper motor neuron tracts, but it also, I'm showing you on this slide, activates our regulatory centers, the cerebellum, the basal ganglia, and we do have conscious control over it. You guys good? So it's like a series of, yeah, that's how our body works. Get it going, and then micro adjustments. That's exactly true, Michael. Awesome. 2. Sahar says 2. Oh, for walking 2. Yeah, for any ambulation, any movement. Yeah. Now the last classification of movements is fine control. Now what's going to be very specific in terms of tracks with reaching and grasping or fine control? The main sort of lateral upper motor neuron tract, the lateral corticospinal tract. Now, our control of fine movements is sort of the topic of motor control and learning, which is the 3rd-year course that I teach. But it's utilizing sort of our sensory information and then contracting our muscles in a way, right? Our primary motor cortex, and then it's our cerebellum that learns how to organize the muscle contractions, so that way we sort of are able to perform goal-oriented tasks better and better through learning. Sorry to interrupt. Who has a dog? Do I have a dog? Carolyn? Okay, that's an answer. Just continuing on with reaching and grasping. So from this slide, we're going to utilize sort of our, okay, someone's coming to dog. Oh, cool. Awesome. Keep dog, bud. The dog would utilize a rubrospinal tract because it's 4-legged. So it would also utilize both not the lateral corticospinal tract, but also the rubrospinal tract in fine control. However, as we know with dogs and other animals other than sort of like apes, they don't have good control of their hands. So great, Matthew, for bringing up that your dog as an example. It's real smart. Bonus marks. So with reaching and grasping, the last classification of movement, we're also going to utilize our sense of vision and somatosensation. Right? We're going to see the environment. It's going to give us an idea of how we have to contract our muscles, what we want to do. And then as we are going to, like, let's say I'm going to pick up my mask, right? I'm going to pick up my mask. I'm going to get a sort of an idea of how I have to move. And then in real, so right, let's feed forward. I'm going to activate my muscles for fine control in a feed forward fashion. And then as I'm doing that, maybe it moves, or maybe I slip, or maybe when I grab it, it kind of slips a little bit. I can also adjust my muscle activations, make micro adjustments in a feedback fashion of those fine control muscles. Yep. Boom. Thank you. Bam. Right? So let's say I'm going to reach for this coffee, okay? So I'm sitting here, I'm going to reach for the coffee. So I've decided in my frontal cortex, I'm going to grab the coffee, probably around the middle. So I have an idea of how I have to contract my muscles in a way to make that position happen. Okay, so I'm going to reach forward and grab. I'm using vision to sort of make minor adjustments, and then when I grab it, what happens if you ever grabbed a box and then it's lighter than you thought, so you go and then you contract it too hard, so you move up too quickly. You stop doing that because you sense that it's too light, and then you make an adjustment to slow down your contraction. So again, just like with talking about postural control, we have feed forward and feedback control of those tracks. Now with reaching and grasping, it more utilizes the lateral upper motor neuron tracks, specifically the lateral corticospinal tract. You guys okay, everyone? Promise? Okay, great. So let's go on to the peripheral nervous system. So I find that once we got through sort of how the big parts of the neurological system work together and getting through the movements, that the rest is sort of, the rest of the course isn't too difficult in terms of sort of the material. Let me know what you guys think. But now we're just going to be describing how when the nerves exit the vertebral column through the spinal nerve, sort of what happens. The peripheral nervous system is important. It's also important clinically because a lot of the neurological sort of conditions that we see in clinic are as a result of issues with the peripheral nervous system, not with like the sort of tracts that are coming through the brainstem and the spinal cord. So here we have a slide depicting what happens. I don't know if you guys can see it, but if you look, you can see the spinal cord. Now, the spinal cord has a dorsal and ventral root. What is the ventral root for? Anyone? The ventral root is for motor. Yes. Yep. And then the no, efferent, the pole. Yeah. And then the blue or the dorsal is for sensory. So it's for afferent information coming in. So see how we have the two roots? Remember the spinal, they recombine to create the spinal nerve. The spinal nerve is mixed. So spinal nerves are both sensory and motor. But if you look at the vertebral column, once we have the spinal nerve exiting on each side, once it exits the vertebral column, it splits into two. They're both mixed, but it splits into two called the anterior and posterior rami. Okay? Our peripheral nerves, because they're a combination of the dorsal and ventral root, they're all mixed nerves, which means they have sensory, motor, and autonomic axons. And then in terms of our autonomic nervous system, our ganglia, their sympathetic trunk, is located outside the vertebral column. So these are the components of our peripheral nervous system. If I take the next slide, it's just a zoom in of that slide. So we can see here is a cross section of the spinal cord, the dorsal and ventral root. See how they recombine and be both mixed. Here we have this, all of this is the anterior ramus, and this is the posterior ramus. So as soon as the spinal nerve exits from the vertebral column, it splits again into two mixed halves called the anterior and posterior ramus, depending on which way the two go, or the divisions go. And I think a good thing to remember from this slide is that the anterior ramus is a lot bigger. It innervates the skeleton, the muscles, and skin of the anterior part of your body and the lateral part of your body. The posterior rami, which is smaller, is innervating the muscles on the back end of your spinal cord and the skin of your back. So if you look at the anterior versus posterior rami, the anterior rami is bigger, it's thicker because it's innervating more areas. Now clinically, we did say that all of the peripheral neurons are mixed. So therefore, if we have a issue with the peripheral nerve, we're going to lose sensory and motor, and that's the key. Clinically, it's important to note that, so has anyone ever heard of a disc herniation? So for Lauren, question. Anterior rami is for, so the spinal nerve is divided into two. The anterior rami is for the front and like, so the muscles, the skeleton, and the skin of the front and sides of your body, whereas the posterior rami is for the muscles and the skin of your back. But when talking about a disc herniation, you can guess where the nerve is being pinched or which spinal nerve is being affected because you can look at which dermatome is being affected. Do you guys remember dermatomes? It's the skin area or the cutaneous innervation associated with a particular spinal nerve. So one way clinically to note if someone has like a nerve issue, if it's the spinal nerve or if it's a peripheral nerve, which of the two are being affected, what you do is you look at the mapping of where they have lost their sensory because the mapping is a little bit different. The peripheral nerves have a different mapping than the dermatomal distribution. So if I go to the next slide, you see how this is our dermatomal. This is the innervation associated with each of the different spinal nerves. Whereas on the other side, in sort of like the not colored or skin color or whatever, beige, this is what the peripheral nerve distributions are. They look different, right? Kind of similar at times, but they're different. And so that's one way to tell clinically if the person has a nerve pinch in their spinal nerve or in a peripheral nerve, right? The nerve is more distally. Because once spinal nerves come out, through the anterior posterior ramus, they recombine to create different peripheral nerves, like our ulnar nerve, median nerve, sciatic nerve, all the different nerves in our body, peripheral nerves in our body. If someone has a problem with a peripheral nerve because they're mixed, they will have these sort of clinical presentations. They can have weakness, which is paresis or paralysis of that area. They can have sensory loss. They can have abnormal sensations. If the muscle's not working, they can atrophy. And then because, remember when we did the deep tendon reflexes, I think 2 lectures ago? It has to get to the spine through peripheral nerves. If a peripheral nerve is being pinched, they can lose or they can have reduced reflexes, tendon reflexes. So when you go to the doctor, they're going to look at, or therapist or wherever you're going to get treated, they're going to look at sort of these presentation to see if these symptoms are there, because that'll give you an idea that it's a peripheral nerve that's being, or a nerve issue that is causing the issue. Now let's quickly talk about the peripheral nerve anatomy. Now, peripheral nerves, they're sort of bundled together, right? So when we look at a nerve, it's like a wire. Now, we had talked about the 3 different connective tissue layers of the spinal cord. You guys remember that? Dura mater, arachnoid space. You guys remember that? Now, there's also 3 layers of our peripheral nerves. They're the connective tissue layers that are continuous with the dura mater of our spinal cord. Those 3 areas, or the 3 sort of connective tissues, are our endoneurium, our perineurium, and our epineurium. Okay? Now, the connective tissue is there to hold everything together. And it's helpful because we have little blood vessels that go into our nerves that help supply the neurons that are within the axons, or within sort of like the nerve bundle. The connective tissue of the nerve is very important because think about the nerves move when we move, right? They're under tension if I reach. You need the connective tissue to take the tension, so that way none of the tension goes to the axons. Because if the axons are getting pulled, we're going to lose the channels, or it's going to affect conductions, right? Everything has to be held together, so that way, remember, the whole point of the neurological system is to send from a signal from one area to another. So it's super important that the tension goes to the connective tissue layers and not to the actual axons in the nerve. So if you look at a cross-section of a nerve, see how we have like the little, well, there's 3 bundles here. Can you guys see the stain, like the little circles? Each of these black circles, if you look at the slide, represents an axon. It's the myelin that's stained dark, so you see the black circles. In between each of the little axons is endoneurium. So it separates each, so all of this connective tissue, all this white, is holding everything together. Right? The black is the myelin because that's the stain. It's holding all of the axons together. Do you see how we have 3 bundles or fascicles of axons? The perineurium is surrounding each fascicle. Now, different nerves, will have different amounts of fascicles or bundles, but in this case, we have 3. We can see that they're separated by perineurium. And then that means the last connective tissue layer, the epineurium, surrounds the whole nerve. So connective tissue layers are there to hold everything together. It's also important because it allows tension to go to the connective tissue layers when we move, and it provides stretch. So that way, the actual axons aren't generating or getting any tension on them, because that would affect their conductance of the action potential. Now here you can see, in this slide, you can see little blood vessels. The blood vessels are there. They come through the connective tissue, and they're also protected from the axons. So the connective tissue layer is also important for blood supply. Because remember, we know now that the neurons utilize so much energy. So blood flow is super, super important. You guys okay with that? So endoneurium, Jacob, is the connective tissue layer that's in between the individual axons, whereas the perineurium is surrounding fascicles, and then the epineurium surrounds the whole nerve. Okay, so as you can see in the slides, that's what I just said right there, that the endoneurium is in between the individual axons. Remember again, peripheral nerves are mixed, so they have sensory, motor, and autonomic branches inside. Now, peripheral axons are going to be classified based on speed. And so remember we talked about like 1A versus 1B, 2, and then gamma. The speed of the neuron is going to be based on its thickness as well as the myelination. This slide here, I just wanted to sort of just state that as the spinal nerves exit every level of the vertebral column, remember they divide up into the anterior and posterior rami. The anterior rami in these 3 areas recombine to create plexi, or combinations of recombination of the axons or the nerves to create our big peripheral nerves. So in the cervical region, we have a recombination to create all the peripheral nerves in our neck and diaphragm. Have you guys ever heard of the brachial plexus? Have you guys done anatomy? The brachial plexus is the recombination of our anterior rami to create our main peripheral nerves in our upper limb. The anterior rami in the lumbar region are recreated, the lumbar plexus creates the peripheral nerves in our lower backs or hips. And then the sacral plexus is for the peripheral nerves that go to our leg and foot. So now this isn't going to be on an exam at all, but it's to show that the nerves, so anterior rami, they recombine to create the peripheral nerves in the head. Brachial plexus, this is all going to your arm. So they recombine. This is all the anterior ramus. See? Ventral rami, spinal nerves. They come out, recombine to create peripheral nerves. So that's why we have our peripheral nerve distribution. It looks different than the spinal nerve distribution, because the peripheral nerves are recombinations of the spinal nerves. This is an example of the lumbar plexus, and then this is the sacral plexus, and this is our big sciatic nerve. So see, we have anterior rami of our lumbar sacrum area. They recombine to create the peripheral nerves that are going to our leg. You guys understand that? You're not going to be asked to, again, like I'm going to have 1,000 emails. You guys aren't going to be asked to like sort of describe any of these diagrams. It's just to show that, again, it's just recombinations that of our spinal nerves or anterior rami that create the peripheral nerves that are going to the different parts of our body. That's why we have a peripheral nerve distribution that looks different than the spinal nerve distribution. You guys okay? Guys? Okay, awesome. Cool. Okay. So when we talked about axonal transport, remember we talked about how it's important to have axosomal transport, right, to get the neurotransmitters from the cell body and down. Nerves need a lot of energy and nutrients because they're always working, right? With the action, with the sodium potassium pump, they constantly need energy. Now, the whole nerve itself is movable, right? It moves between the muscles, right? So, or else if it got caught, like let's say I stretched my arm in a crazy range of motion, if the nerves didn't move or stretch, everything would just rip. Or the tension would go on the spinal cord and that would rip. That's not good. So the neurons or the nerves themselves, the peripheral nerves, they move. They stretch and they move. Now the movement is important because it helps keep the fluid within the nerve, the peripheral nerve. It needs a lot of blood flow, so the movement's going to help with blood flow and the moving of the axoplasm that's going to create the sort of hold the nutrients and oxygen. So nerve moving is good. What happens when we see peripheral nerve injuries? We see like, carpal tunnel. Things haven't moved, they get stiff, the muscles get stiff, it gets inflamed. Things don't move, and so it decreases the sort of movement or the health of the neuron, or the nerve, sorry. So when we say like stretching is important, moving the body is important, because you need motion to maintain homeostasis. And in terms of the nerves, you need that movement to help optimize and promoting the blood flow and the movement of the exoplasm of the peripheral nerve. So here we have a cross section. So remember how before we looked at a cross section this way? Now we'll look at it this way. So you're looking at this. So this is the wire. What do you notice about the sort of like the wires, the axons? See how they're like kinked? That's not straight. That means that the peripheral nerves, they are stretchy. Like if you take a nerve, don't take a nerve, but if you take a nerve from like a cadaver, it stretches. It's like an elastic. Because again, you need to move without having tension on the axons. So you can see that the endoneurium is elastic. So it's in between the different axons. But what happens is it allows for stretching of the peripheral nerve. Super important because you don't want tension on the axons, and then you won't get proper action potentials. Can we still break it? Yeah, like anything, you can still break it. So then our peripheral nerves, we're going distally. Remember, they have motor, sensory, and autonomic, right? They're going distally. Now, when it gets to the muscles, what happens at the muscles? There's a neuromuscular junction. Now, the one thing that I want you to remember from the motor lecture is that, remember, if we activate a motor unit, a lower motor neuron will send an action potential to all of the muscle fibers it innervates. So it's not like there's summation at the muscle. Whatever there's an action potential, the lower motor neuron, whatever muscle fibers it attaches to, are going to contract. So it's an all-in-one response. That action potential or all-in-one response goes from the lower motor neuron to the muscle fibers. It's one unit. It's a motor unit. Okay? So I just want to sort of reiterate that from this slide. Okay. So now let's talk about clinically what happens, right? Do you guys find the material too difficult thus far? I find that this one's a little bit easier for everyone. Okay, so remember, our peripheral nerves are mixed. So sensory, motor, and autonomic. If you get those issues, they're going to be distributed in a peripheral nerve distribution, not a spinal nerve distribution. They're going to be, let's say you have a loss of sensory because of your median nerve is gone. You're going to have a loss of where that median nerve would go. Okay, so these are some of the sensory changes that you would see. They contain all of the different tracks. So you would have changes in potentially, if you had sensory changes in terms of a peripheral nerve injury, you would have issues with fine or crude touch, proprioception, vibration, pain, and temperature. Now, clinically, you can see these terms, and you may have heard of them before. Hyperalgesia. So algesia means pain. Hyperalgesia means you increase sensitivity to pain. Dysesthesia. This means dysfunction. So problem with sensation. So dysesthesia means abnormal sensation. Paresthesia means numbness or tingling. And allodynia means you perceive a normal stimulus as painful. So when an area is very sensitive, like if you touch a normal skin, no pain, you do the same pressure on an area that's sore and it's sensitive, that's called allodynia. Now there's no set injury that causes one of the particular symptoms. If you have issues with a peripheral nerve, you may have all or just one. It's just because it's affecting sensory, depending on what neurons and what axons are getting affected, you can have these sort of like presentations. But it's all just sensory issues, right? So when someone comes in clinically and they say they have like sort of like these layman terms issues, clinically it's what this is, but then I know that, okay, I got to check in your peripheral nerves, or I got to check the nervous system, something's up neurologically, versus I pulled my quad and my quad hurts when I flex my quad. Then it's idea, okay, it's probably quad muscle, not neurological. Motor changes. So if you have an issue with the peripheral nerve, you're also going to have issues with not just sensory, you're going to have motor issues. The motor issues that you can have are weakness or paralysis. So weakness is the weakness of voluntary movement. If you have an issue with the peripheral nerve and only some of the motor units are getting affected, you're going to have weakness versus complete loss of movement. That's called paresis. Paralysis would be like if you have a complete injury of all of the motor axons in that peripheral nerve, you're going to have inability to use those motor units because they're not there anymore. That results in paralysis. Now, paralysis, when muscles aren't being utilized, what happens? They atrophy. And that happens really, really quickly, actually. So if someone has a long-standing paralysis issue, when they come in, you're going to see that their one limb is smaller than the other. You're going to have muscle loss. Now, one thing that you see clinically sometimes is you see fibrillations. And the fibrillations are when you have atrophy, sometimes the muscles will go in spontaneous like twitches every now and then. It's not because the nerve is trying to regrow. It's because there is a upregulation of acetylcholine receptors because the body's trying to figure out why the signals aren't getting through. So it just adds more receptors. The problem is that because the neuron's not working, the neuromuscular junction isn't sending acetylcholine. But there's always some like little bits floating around. So you'll sometimes see with the increased number of receptors, sometimes they'll catch just a random floating one, and you get a little fibrillation. So fibrillations are what you see in atrophy as well. Oops. Okay. And then the last sort of system or change that you would see with injury to a peripheral nerve are the autonomic changes. Now, the autonomic system was for regulation of like blood flow and homeostasis of the body. So the autonomic changes with a peripheral nerve would be the homeostasis, like sweating, blood pressure, and autonomics and homeostasis stuff to that particular limb. If we have an injury to one peripheral nerve, the autonomic changes that we're going to see. So typically, when the nerve is completely severed, is when we see the autonomic changes. So when there's a huge injury, when the nerve isn't working at all, so severed meaning cut, we'll see that if it's to a single peripheral nerve, we'll usually see that we'll have like a loss of sympathetic control to that limb. So whatever limb the nerve is associated with, we'll see a lack of sweating and like a loss of sympathetic control to smooth muscles. So the contraction of our capillaries and our blood vessels. And so what that leads to, if we can't control the contraction of our blood vessels, the limb swells. So usually the main autonomic symptom that we see in like significant peripheral nerve injuries is the limb swelling or limb edema. Now, we regulate our blood pressure in our body through the contraction of our blood vessels like all over our body. So if we have enough peripheral nerves or many peripheral nerves that are significantly affected, it's going to affect our ability to regulate our body. So if we have lots of nerves that are peripheral nerves that are getting affected, significantly enough to cause autonomic changes or autonomic loss, control of homeostasis, we're going to see problems with regulating whole body blood pressure, heart rate, whole body sweating, and bowel and bladder functions. Impotence is like inability to get an erection. So fasciculations are when you're actively using neurons. Oh, sorry, question from Pardis. So fibrillations are when you have, in the skeletal muscle, is when you have tiny microcontractions in the atrophied muscles as a result of the upregulation of acetylcholine receptors. So it's not as a result of action potentials. Whereas with fasciculations, they are usually as a result of action potential getting through and trying to contract the muscle. Is it okay? Yeah, cool. So the autonomic changes that we see, the grouping of what happens when we lose autonomic regulation to a limb as a result of a peripheral nerve injury, it's called trophic changes. So the trophic changes are the things that we see in the soft tissues when there's an interruption of the nerve supply, specifically the autonomic nervous system. So when we have a significant peripheral nerve injury, we're going to see muscle atrophy because you can't flex the muscle. We're going to see edema and blood supply changes because the autonomic system isn't being utilized. And so what happens is when the limb swells, doesn't get a lot of blood flow, and it becomes shiny. And I have some pictures after, and it becomes brittle and thick. And as a result of, and I don't know if you guys know anyone with diabetes is a classic one, because of a loss of sensory, you can't tell if how you're walking. So sensory issues, particularly in diabetes, once you have a loss of sensory, you can't tell if you've hurt yourself, right? So usually when you hurt yourself, you try to not hurt it anymore. People that have diabetes or for example issues with their foot, they can't tell that they've hurt their foot, and because there's already a loss of blood supply because of the autonomic system, the injuries that are there that you're unaware of aren't healing, and so you get ulcers because you can't feel the joint. You also get neurogenic joint damage, and we'll talk about a really common issue. Does anyone know what CMT is? Charcot-Marie tooth. It's a neurological disorder that leads to inability to have a sensory and motor in your feet. And so what happens is the people have sensory everywhere else. So they're trying to walk because they can't feel their feet. They try to mash their bones in their foot so it's stable. And so it grinds the joints, which should hurt, but they don't feel it. So they don't know. So that over years and years leads to degeneration of the bones in the foot. So that's called neurogenic joint damage. But typically when you see trophic changes, you see lots of ulcers because there's already loss of blood supply. The skin's brittle, and then people can't tell when they've hurt themselves. So if anyone's squeamish, don't look, but here's an example of ulcers. So you can see that the skin is brittle, it's shiny, it's thick, it's swollen, look at how swollen it is. Here's an example of trophic changes. So they can't flex the muscle, so it's atrophied. Look at the nails that are all overgrown. It's swollen because there's no autonomic regulation. Loss of blood supply, meaning little injuries that happen don't heal. And this progresses and progresses and progresses because the person can't tell. So what do you tell diabetic people? You tell them to look at their feet all the time and try to maintain care. And so all of those diabetic clinics, because they're also older, right? So they're not really sort of aware. So it's about wash all the time. Look at your feet, proper wound healing, put a Band-Aid on, let your feet breathe. Okay, you guys okay with that? So now what we're going to do is we're going to finish off the lecture with talking about the sort of classification of neuropathies. So now we understand the different changes that you can get with peripheral nerve injuries. There's 3 different classes of nerve injuries based on sort of the grading of them. So the first grading system is how many neurons are getting affected. So we have mononeuropathies, which is when we have one peripheral nerve being affected. Multiple mononeuropathies when we have multiple peripheral nerves getting affected in one similar area. And then polyneuropathy is when we have multiple systemically peripheral nerves getting affected. So this is the classification of neuropathies. Single peripheral neuropathies, single nerve, multiple single nerves, right? So let's say you have loss of blood flow to one specific area, 1 or 2 or 3 peripheral nerves in that area are going to get affected. Whereas with polyneuropathy, it's systemically. So you typically see with polyneuropathies, peripheral nerves symmetrically, like from both limbs, being affected. Let's go through that. Let's first talk about mononeuropathies. That's when we have an injury to one peripheral nerve. There's 3 classifications or 3 gradings of injury. With mononeuropathies, so an injury to one peripheral nerve, we have 3 different severities. An injury where it affects the myelin, an injury where it starts affecting the axons, and then complete severance, or like the cutting of the neuron. So 3 different groupings. Remember, this is injury to one peripheral nerve. A traumatic myelinopathy refers to when there's pressure or repeated trauma to the neuron, it tends to stop exoplasmic flow, and so the myelin degenerates. So the first thing to happen with repetitive strain disorders or like peripheral neuropathies is that they lose their myelin. I mean, the nerve works, but it slows down in one area, so it doesn't work well. Now, typically, what we see in terms of traumatic myelinopathies are our nerve entrapment symptoms in our body, like sciatica, carpal tunnel syndrome, thoracic outlet syndrome, piriformis syndrome. Have you guys all heard of these? Like they're like fairly common, like clinical terms, but these are all mononeuropathies with a grading system of traumatic myelinopathy. They're as a result of repeated trauma causing a breakdown of blood flow and therefore a reduction in the myelin at a particular part of that peripheral nerve. So this is going to lead to issues with motor, sensory issues, and it's as a result of focal compression of a peripheral nerve through repeated mechanical stimuli, including excessive pressure, stretch, vibration, friction. And what this does is that it causes inflammation and restricts blood flow and exoplasmic flow, which we know is important, right? The movement of that is important for the peripheral nerve health. Once that sort of is reduced, the myelin in the area degenerates. You guys okay with that? Everyone? Cool. So here we have an example of carpal tunnel syndrome. Does anyone have carpal tunnel? This is where it's a nerve entrapment of the median nerve in the carpal tunnel. Really common with like typing, right? So repeated trauma of our hand leads to a mononeuropathy or a traumatic myelinopathy of our median nerve. So here's the area that's injured, and the nerve goes to our first 3 fingers. So everyone's saying that you get carpal tunnel during exam season. Yeah. But because of the repeated like sort of excessive pressure and repeated like force to that area, we get inflammation, and then we get a loss of sense in these 3 fingers. That's where the sensory is. And then we get a loss of muscle in the thenar eminence. So the median nerve is for the like this area. So if there's muscle atrophy, see that on the picture, see how the guy has, or whoever the person has sort of like an indent? It's because they have like loss of the thumb muscle. So that would be after a significant amount of time. Here's an example of a mononeuropathy, a traumatic myelinopathy. You guys okay? Guys? Okay. Here we have what it would look like under a microscope. So remember the myelin is stained black. So here we have like this axon, it's lost its myelin. Okay. The next level of a mononeuropathy is traumatic axonopathy. This is where there's significant enough trauma not only to affect the myelin, but it's also enough to disrupt the axons. So typically, has to be significant. This is typically this is a result of crushing via dislocations and closed fractures. So has anyone ever dislocated their arm or fractured their leg or anything? The first thing that they do in the ER is to make sure your sensory is there and motor, because when you have a break in the arm or a dislocation, when you're like because the muscles contract, it tends to come back together. If the nerve was caught in that area, so caught in the area between the bone or caught in the area between the joint, it would get crushed, like crushed hard. So then if that happens, it's enough trauma. It's not repeated like minor trauma to cause a myelin issue. It's enough trauma to break the axons. Now, because of all that connective tissue, the nerve isn't severed and it's not broken in half. It's just crushed. Once the axons are crushed, the way to heal the nerve, let's say they take the pressure off, the way to heal the nerve is through Wallerian degeneration. Have you guys ever heard of that term before? If you have a significant enough injury to a peripheral nerve where the axons are affected, you don't just stick it together and the axons regrow together. Everything distal has to die, and then the axons have to regrow from the proximal stump. That's why nerve injuries take so long to heal. They heal at about like 1 millimeter a day. Because you can't recombine them. It has to because the connective tissue is there, the axons will regrow following along where the connective tissue was. It's like a nice map. So it'll regrow, but it takes forever. It has to regrow. So let's say this is proximal, right? It dislocated my arm, it got crushed. So the nerve got crushed. All of these axons are going to die, and then it has to regrow all the way down. Takes forever, yeah. But with rehab and trying to use it, by trying to get signals down to the stump, it tends to make the axons grow in a better way, faster. That's what the rehab is for. So when we have a traumatic axonopathy, it's a significant enough injury where all the axons are crushed for a particular area, we're going to have loss of motor, sensory, and autonomic. And then the last classification of our, and it's the worst one, of an injury of a peripheral nerve is severance. That's when we have our nerve cut in half. That's when we have the nerve physically divided by either like stretching and ripping in half or a cut. Does anyone, like, I remember when I was in undergrad, like one of our like pub nights, one of the guys on our floor punched through the door to our like main like hallway for our dorm, and then he pulled his arm out, like he punched through the glass. You know how it has like the metal, like the grid. He pulled it through, and it like cut off his arm and like cut off all of the like severed all the nerves in his hand. So he couldn't even use his like the nerves weren't working. So that's severance. So he had to reattach everything. Yeah, it's horrible. Well, no, it didn't deglove him because it just stabbed him. It just cut the nerves. Degloving is different. I don't know. I don't have him on IG. I wonder. Let's take a moment to remember this man and hope that he is okay. But when we have severance, it's worse than an axonopathy because the connective tissue isn't there. Like there's no grid for the axons to regrow because it's severed. So what the surgeons have to do is they have to like try and get the nerve and sew it back with microsutures the way that it was and hope that they lined it up correctly. So that way when the axons regrow from the distal end, it'll like follow the mapping of the connective tissue. That's why it's hard to like recombine nerves. Is everyone okay with that? So mononeuropathy was the first classification. Injury to one peripheral nerve, then there's 3 gradings. Myelopathy, axonopathy, severance, right? That's when you injure one peripheral nerve. The next sort of grading, or the next sort of classification, is when we have multiple single peripheral nerves injured, multiple mononeuropathy. And that's typically as a loss of blood flow to a specific area in the body, like a particular limb. The first thing that's going to go is our neurons. So maybe you'll have, like, so let's say I lost like blood flow to my arm for some whatever reason, right? So I put like, who knows? You could have an injury where you have loss of blood flow to one particular area. The peripheral nerves that are in this area are going to die. So now we have a injury to multiple peripheral nerves, and that's classified as a multiple mononeuropathy. It's typically it's not symmetrical. It's not like equal both sides of the body. It's particularly just one area. And it's as a result of reduced blood flow, which could be like vasculitis is the main reason, diabetes sometimes. You get like one blood vessel that can like sort of be affected. But when you have a loss of blood flow to one area, you get ischemia or like no oxygen going to that part of the body. The nerves in that area will die. And then the last classification is when we have a polyneuropathy. Now these are very, very common. And they're usually as a result of blood flow or a buildup of metabolites, and they present in what's called a symmetrical pattern. So the most common one that we talk about is diabetes. Typically, with polyneuropathies, they're as a result of blood flow or a reason that blood flow isn't going to one area. And so polyneuropathies, you get a loss of sensory motor or autonomic changes symmetrically. So they present in what's called a stocking or glove distribution. Now they're typically common with diabetes, nutritional deficiencies, and autoimmune diseases because you had a buildup of metabolites in our capillaries. And so we have typically, you see the, so if people present with neurological issues, you see them in a glove and stocking distribution, meaning that you see them in the hands and feet symmetrically. If it was a multiple mononeuropathy, you would see in just one part of the body, like one limb. See how with polyneuropathies it's affecting like this symmetrically? It's because it's as a result of a collection or a loss of blood flow to parts of the body. So for example, diabetes. Do you guys know why diabetes causes blood flow issues? The actual diabetes is you can't regulate your blood sugar. The actual molecule for sugar is sharp. So what happens is when you have more sugar in your blood, it tends to cut the small little capillaries distally. Remember how as you go more distal, the blood vessels get smaller and smaller? It tends to cut all the capillaries, so you get a loss of blood flow most distally, so in the hands and feet. A lot of other nutritional deficiencies or autoimmune disorders. With also autoimmune disorders, remember you get a buildup of antibodies, and then the antibodies cross-react, and so your body starts attacking those antibodies. They would sort of collect in the small capillaries, so then you get it happening with the hands and feet. So a lot of these different systemic sort of diseases cause neurological deficiencies in a glove and stocking distribution because that's where the blood flow is most distal. It's where the blood flow slows down. So you get a buildup of metabolites there, you get a buildup of antibodies there, you get a buildup of the sugar molecules that cut the blood vessels there, depending on like whatever the disease is. Well, we'll learn about Charcot-Marie-Tooth. That's when you have a breakdown of different proteins. Happens distally. Okay, you guys okay with polyneuropathies? So the difference between a polyneuropathy is that it's symmetric. And so what you see are these diabetic issues. So here's an example of diabetic polyneuropathy. They get a buildup of the sugar molecules, cuts all the small little blood vessels, and they get a loss of blood flow distally. So typically what happens is they get a loss of sensation in their hands and feet. It's diabetic. But because they're walking on their feet all the time, they tend to get little micro injuries that never heal because they never take care of them. And so they get like these injuries, then they ulcer. Another example of a polyneuropathy, and I will show you guys, I would look at this video on your own time. It's just depicting Charcot-Marie-Tooth. Now this is one of the most common inherited polyneuropathies that you can get. And so what happens is that if it's because of a gene loss, it is affecting the production of proteins in neurons. And so what happens is you get a loss of, you get a degeneration of the neurons, and it happens most distally because of blood flow. And typically what happens is that with Charcot-Marie-Tooth, you get a loss of sensory and motor, and it typically happens in the feet. Now it's more significant in terms of a progression than diabetes. So what happens is that the people, they don't feel their feet, they don't have pain, but they're still mobile and they can still walk around. And so what they do is, imagine trying to, okay, this is sounding super gross, but imagine trying to walk on a floppy foot, right? So this is my foot and it's floppy. You can't tell that it's floppy, you just can't control it. And there's no pain, you don't feel it. So what the people try to do is they they try to walk on the side of their foot, like this. So watch the video. They try to jam all the bones so it makes it stable. And then that over years leads to like there's a crazy breakdown of all of the bones. This is the reason why I'm presenting this is because it's one of the most common polyneuropathy examples. It's inherited, and it progresses as the person goes from adolescence to sort of young adulthood. And the characteristic symptom or presentation of these patients are that they have like this classic high arch and clawed toed look. See how right here? It's because they're starting to put pressure here because they can't control their foot. When you take an X-ray, normal X-ray, Charcot-Marie tooth, all the joints are all broken down. Well, so Theo asked, can you stop the swelling from happening in the feet? Well, the problem is that it's not, they don't feel it, so they don't know that there's a problem. Typically what they do is you give them like, not orthotics, you give them orthos, you give them like foot braces. Have you guys ever seen like those like really, like you put them in your, like they would hold the foot in position. Orthoses. This is typically what you give people with Charcot-Marie tooth. Is that what you meant, Theo? Yeah, because the swelling is as a result of the breakdown of the foot. The problem is that if you stop walking on breaking down the foot, then the swelling would go down. The people don't feel anything, so they just don't ever stop. They don't think there's an issue. So I just wanted to finish off with talking about because we were talking about like clinical injuries with peripheral nerves. If you have like paralysis or paresis, it can also be as a result of issues with the neuromuscular junction. So the neurons are working. It's just that you're not getting the action potential from the peripheral nerve out to the muscle. Myasthenia gravis is what we've talked about. That's when we have a loss of acetylcholine receptor. So that was a question on one of your tutorials. You guys ever heard of Botox? Botulism is a sort of it's a poison that's produced by bacteria, anaerobic bacteria, that it stops the release of acetylcholine at the synaptic terminal. So taking botulism toxin, so this is like a anaerobic, so it used to be in canned food. Anaerobic, it would grow this bacteria, and then you eat it, and then you get this neurological disorder. What we do is clinical. We took that toxin and then we use it now clinically because what it does is it prevents acetylcholine from being released at the motor unit or the neuromuscular junction. So it's a way to stop muscles. So with Botox, what you're doing is you're injecting this botulism toxin into areas to stop the muscles from contracting. And what that does is like when people take like a lot of Botox, like their face is like not wrinkled, but it's like, oh, I'm so sexy. Because all the muscles are like not able to contract. Okay, and then just finishing off with the last little thing, guys. We want to look at like certain terms of like sort of like clinically what we can do to assess the type of peripheral nerve injuries. Typically, what we do is we do electromyographical or nerve conduction studies to test the sort of like conduction in the nerve. So what we do is we take, I don't have a picture, but if you were to like, so have you guys ever heard of a nerve conduction test? They're pretty common. So with a nerve conduction test, what they do is they take a needle and put it at the beginning of a peripheral nerve, and they take another needle and put it at the end of the peripheral nerve. And they send electricity and then see how the conductance is. They look at the size, so like the initiation of electricity is going to be at a certain potential, like a certain amount, and then the speed. They look at whether or not the signal is able to be conducted, and that's going to tell you if the nerve is working. So remember how with myelinopathies, it's just myelin allows for the nerve to speed up. So if you have a myelinopathy, you're going to see a reduction in the speed of the electrical conduction. Whereas if you have an axonopathy, remember axons are being crushed, so some of the axons are gone, you're going to have a decrease in the amplitude of the electricity. So this slide here is just showing the difference between using a nerve conduction test to look at whether or not the injury to a nerve is either a peripheral nerve is either a myelinopathy, so grade 1, versus an axonopathy, which is a grade 2. Myelinopathies show a decrease in speed, whereas axonopathies show a decrease in amplitude. Everyone okay? So clinically, to assess whether or not someone has a peripheral nerve injury, and the most common peripheral nerve type of stuff that people come into the clinic are typically with diabetes. So you want to look at the sort of like neural integrity of the foot. So when people come in with issues with walking, what we do is we look at the reflexes, we look at their proprioception and whether or not they can. So some diabetic patient comes in, we will look at the ankle reflex. It's going to tell us whether or not the sensory nerves are working. We're going to look at whether or not they can, like, you close your eyes and move your big toe. Can you tell me if the toe's up or down? And they can feel it. And then we look at whether or not they, okay, so, you know, the vibrating hammers. Tell me when I'm touching the foot. So it allows, so this is just testing their sensory integrity. And that is it, guys. So just finishing off with types of treatment. When you have treatment for nerve entrapment syndromes, so once you've diagnosed that you have a neurological disorder, nerve entrapment syndromes, you typically try to take pressure off, heal the inflammation, and get them to strengthen that area. So when people come in with like carpal tunnel or for sciatica, I do like acupuncture, I do different modalities to help take the pressure. Usually it's the muscle and inflammation pinching on the nerve. Do modalities and stuff to take the pressure off, and then you get them to strengthen the area, so that way you're trying to get signals and getting the nerve to regenerate, and movement is going to help with the blood flow of that neuron to heal it. Anti-inflammatories will help. Sometimes you get surgical release. So what was popular before was like releasing the carpal tunnel. Now they don't want to do that anymore. They realize that it just comes back. With axonopathies, I did say that when you want to rehab the area because it was a loss of the axon, there's Waddellerian degeneration, meaning that the axon has to regrow down. The way to sort of speed that up is to try to use the limb, try to get the muscle or the neuron, to work. And sort of by sending signals, it tends to make the axons regrow in the more accurate fashion. Okay, and then, yeah, just read that over. What I wanted to just point out really quickly is that, guys, this part here is just to show you the distribution of the different peripheral nerves for your information. You will not be tested on this, okay? Not be tested on this. Not. If you want, just delete it. But it's just to show you more in depth that you can tell whether or not a spinal nerve or a peripheral nerve is injured because you can look at where the injury is, the distribution. Okay? Are you guys okay with the lecture today? Everyone's good? Yeah? Okay, good. Okay, everyone, you have a good week. Next week is our last lecture. Oh my God, I forgot to record. It's like, okay, bye guys, bye. I'm a liar.